Good morning, everyone, and welcome to another edition of Meds Ed, our primary care education program brought to you by us here at CareOregon and from the CareOregon pharmacy team. My name's Paul Carson. I'm a training and development specialist with CareOregon, and today we're going to be focusing on the topic of hypertension, high blood pressure. So let me take you through a couple of just minor housekeeping items, and we'll get started if that sounds good to you folks. Let's begin. First of all, I know folks are always curious to find out about CME credit. We are approved from the AAFP for 2 hours of CME credit for this session here today. Very easy to apply for that. When we're all done, I'll be sending everybody who's enrolled an email link. You fill out a quick survey, takes about 30 seconds, and bada bing, you're all done. And then next week, I will be sending out the CME certificates for you. So it's an easy process, very, very stress-free. Here's a super quick overview of some of the topics that we'll be covering here today. Resistant hypertension, chronic kidney disease, management, referral guidelines, all those type of things here. We have some great focus that I think you're going to appreciate that's going to make treating high blood pressure a lot easier to wrap our arms around here. Here's the core learning objectives, just to sort of provide a foundation for where we're going. You're going to be able to have an understanding of a general treatment approach to hypertension, but some special considerations for dealing with comorbid conditions and as well as special populations and how they might be impacted. You're going to be able to demonstrate and identify how to manage chronic kidney disease, which is part of the same thing. And you'll be able to implement strategies for addressing treatment-resistant hypertension, which is something that we're going to be spending a good focus amount because that's out there quite a bit as well. We have to bear in mind. But enough of me setting the stage. Let's bring our two presenters in here and let them take things over from here. There may be a little back and forth, but we're going to divide our presentations into two sections. But what I'm going to do is introduce both of our presenters on the front end here for us today, get those intros out of the way. To start things off this morning, we're going to be beginning our session with Dr. Kate Gustafson. Dr. Gustafson is a full-time clinical nephrologist who completed her internal medicine and nephrology training at OHSU. After 2 years in a nephrology position at the University of Massachusetts and an unsuccessful attempt at readjusting to life on the East Coast, because have you done that? It can be a little different sometimes. She and her family enthusiastically returned to the West Coast. Joining the combined Portland VA and OHSU nephrology department in 2017. She serves as the CKD clinic director at the Portland VA, which affords her ample opportunity to interface with primary care providers throughout the local VA health system. Very fortunate to have both of our presenters here today, and in particular, it's wonderful to have Dr. Jose Rueda with us today. Dr. Rueda has been kind enough to present with us in the past. He's a full-time clinical nephrologist who joined OHSU in 2004 and was the director of the Hypertension Center at OHSU for more than a decade, and now practices at the Portland VA Medical Center since 2022. I'm sure they're going to have other things they want to add about their own background. So let me pass it over to them and we'll go ahead and get started in our focus on hypertension. Let's bring up Dr. Gustafson. It's all yours, my friend.
Good morning, everybody. Well, it's kind of a big topic, but we're going to do our best to cover it. So by the end of this, hopefully you'll be feeling that hypertension, CKD, and primary care are like three peas in a pod in a field, but they go together so nicely. So this is just a little bit more specifics on the objectives for the first part of the talk that I'll be giving. We're going to talk about the definition of hypertension, which we'll spend a very short amount of time on, and really emphasize the importance of its the fact that it's a risk factor for cardiovascular morbidity and mortality, and really is one of the main reasons why we care about it and why it's such an important thing for you all as primary care physicians to identify and manage on the front lines. We'll talk about the importance of lifestyle modifications and blood pressure management, which can be, of course, challenging, but certainly should not be underestimated. And then finally talk about the therapeutic options for hypertension in several special populations, including those Just with essential hypertension in this first hour, Dr. Rueda is going to touch on the resistant hypertension in the second hour of the talk. And then we'll talk about our diabetic patients and our folks with chronic kidney disease, both with proteinuric and non-proteinuric. I'm sure you guys have all seen this before. And I think all of us can kind of say the classification of blood pressure can feel a lot more simple than the management of it. So hopefully you will feel differently after this talk. This slide is based on some data, NHANES data from 2011 through 2018, and it has over 21,000 folks included in this data set. And this is just to show how much hypertension there is out there and how it increases with age. In this set of data, hypertension was considered anything over 120 for the systolic and over 80 for the diastolic. For essential hypertension, unlike some of the causes for resistant hypertension, there's a lot of different things that go into it. We can't put our finger on just one thing. From the environment that we are in prior to our birth to the genetics that we don't really have a choice. We're dealt the hand that we're dealt. So the genes that we're given, to then some of the choices that we make with our lifestyle, with diet and physical fitness and substances that we may or may not use. All of those together combine to give us kind of a set point where a MAP set point. So where a blood pressure set point, which is different from all of us, different for all of us. And this set point is, of course, a moving target. It's not something that's static. And we can appreciate that even on sort of an hourly basis if we think about the concept of a nocturnal dipping. But this is a very healthy and normal phenomenon that sometimes our hypertensive patients might lose, that the blood pressure should drop at night when we're sleeping. And that's just one example of this, how the MAP set point can change through the day. And here is kind of getting back to the point of just how a powerful MAP your blood pressure can be as a cardiovascular risk factor. This shows your cardiovascular mortality versus blood pressure, and showing the increasing cardiovascular mortality risk with rising blood pressure. Showing that both systolic and diastolic blood pressures are important, but really the level of the systolic really confers the greatest risk for cardiovascular mortality. Kind of shocking. And so in thinking about management, guidelines for hypertension can feel a little bit like everything else in our life, like the toilet paper aisle or the cereal aisle. There's just so many to pick from that it can feel overwhelming at times to know which guidelines you're supposed to follow. The ones that we choose to follow, or that I choose personally to follow, I think Dr. Rueda would say the same thing, actually are our VA guidelines here, which I find really flexible, which is why I choose to follow them. So if you'll see, the systolic goal is simply less than 130. And then this really leaves, let me get my point map here. This, I think, is the most important, the clinical judgment piece. And that is what we're all in medicine for, is to do medicine, which isn't always algorithmic. So looking at the patient in front of us and kind of making a decision whether we need to stay on an algorithm or go off of an algorithm. And this set of guidelines, I find, really gives us that freedom to do that. And so a lot of what we're going to talk through in some of our cases today will be based on these VA guidelines. But really, you could go through the same exercise with the cases with any guideline that you might choose. And we'll talk about sort of why one might consider a different guideline than another as we're going through. So case number one is a 35-year-old male who comes to clinic as a new patient. He's one of those patients who comes in with not a lot of medical history, says he's been pretty healthy, not taking any medications. His initial blood pressure, when you get the initial blood pressure recorded in the chart, is 150/90 with a heart rate of 80. He's got a BMI of 32. And so you're looking at the chart before you go into the room, and the question is to see, does this patient have hypertension? The first thing you should ask yourself is, was this blood pressure taken correctly? And there certainly is a correct way to take blood pressure, and there's a number of things to think about. Was the cuff size correct? So sometimes in a busy clinic, when patients are being vitaled, they might only have one size blood pressure cuff, and folks who are doing the vital signs might feel like they don't have time to go look for a different size, and so they might just use the size that they have. But the correct size is really important for getting a correct blood pressure. So the bladder of the cuff should encircle 80% of the arm. You should really have no clothing between the skin and the cuff, which can be especially challenging in the winter. There's lots of layers that can take off. The patient should be sitting for some period of time, not just grabbed from the waiting room with a cuff slapped on them, legs uncrossed, and no talking. Importantly, it should be checked on both arms. And while it's really tempting to use the lower reading, really you should check it on both arms and use the higher reading for treatment. Over here, you'll see this statement down here, which says that patients should measure their blood pressure in the morning, right when they wake up, or in the evening before they go to bed, and try to measure it at the same time each day. This is actually not something that I tell my patients to do in practice. I think it's fine if they do this, but when I'm talking to my patients about monitoring their blood pressure at home, I tell them that these are actually can be the least helpful blood pressures. Often patients will wake up in the morning, check their blood pressure, and take their pills. And really, if you think about it, that's probably the highest their blood pressure is going to be through the day. In an ideal world, you'll have full 24-hour coverage. But for most patients, the meds from the day prior are out of their system. So what I'm interested in treating their blood pressure is to know what their blood pressure is with all of their medicines on board. So I ask my patients to check and record their blood pressures 1 to 2 hours after they've taken it to give their bodies time to absorb it. And then we're not risking over-treatment of blood pressure. So this is the AHA, American Heart Association guidelines in thinking about when do we actually say something is hypertension. Just like hematuria or other diagnoses, you don't want to give someone a diagnosis too quickly. So you do want to make sure it is confirmed. So it should be on more than 2 occasions and averaged between several readings. If you're not sure, you can have your patient check some home readings. And this also will help if you're suspicious about white coat hypertension, which Dr. Rueda will talk a little bit about. And then also important to think about masked hypertension, which we'll talk about in a little bit, which is actually the opposite of white coat hypertension. So back to our case, the repeat vital signs are taken after he's allowed to kind of settle down. His blood pressure is 135/80 and 137/82. So the question is, do we treat him, or what do we do with this blood pressure in this young man? So while the VA guidelines seem very simple, the actual way in which they're drawn up is actually really complicated. So I'm just going to draw your attention to this box right here, which is to say that once a patient has had a blood pressure greater than 120/80 and is noted to not have an acute injury, that we're going to think about implementing lifestyle modifications. And this will be an important point. And actually, before I get to that point, I want to point out here this idea of masked hypertension, which is lower blood pressure readings in the office than you get at home. And one indication that you might need to think about this is if you're getting, say you get a high reading and you do a repeat and it looks great, it's 118/72. But as you're looking through labs or as you're looking through other data for the patient, you notice that they have some evidence of end organ damage. They had a heart attack, or they have heart failure, or they've had some problems with their eyes, or they, as we'll talk about, they've got some protein in their urine. You may want to think about maybe their blood pressures are running higher at home, and that would be another reason to think about getting some home blood pressure monitoring. But so for lifestyle modifications, these are hard, obviously. We know that new habits and changing habits are really hard. And I feel like this is kind of the same thing as smoking cessation, which is also a very important part of lifestyle modifications for hypertension management. You know, sometimes it's the 15th time you talk about it. Sometimes it's the 30th time you talk about it, but it's really important to keep bringing it up. So weight loss, activity, minimizing substance use, minimizing sodium, managing mental health, treating sleep apnea if it's there, and talking about drugs or over-the-counter things that could be exacerbating high blood pressure. These are important things to touch on, and I touch on them, at least some of them, almost every time my hypertensive patients come to clinic if they are not controlled. This is an older slide, but still is very relevant. And this just shows, well, the main thing I wanted to show here is that weight loss gives you kind of the biggest bang for the buck. It's fabulous antihypertensive. And I feel like we're obviously seeing more of this in the Ozempic age. But this is hard. And so, you know, I encourage just really small changes. So if your patient's drinking 6 Pepsis a day, encourage them to drink 5, and then the next time 4. You know, it doesn't have to be giant changes, but small changes over time can really make a difference. Drugs that we think about, that you could think might be not helping you with your hypertension management. Non-steroidals, which we'll talk a lot about, or we'll talk about in a little bit. Decongestants, testosterone, estrogen, any kind of the hormones, ephedra, calcineurin inhibitors, so for your transplant patients that you might be following, fluoxetine, venlafaxine. There's a whole bunch of them. Obviously, alcohol, cocaine, and a lot of the IBs and MABs can cause hypertension as well. So, you know, not necessarily things that patients can come off of, but important to know that they can be contributing. So, you know, obviously some of them we can come off of and encourage our patients to use cocaine less. That's what they're using. So for our patient, again, we take more of a history and we find out that he is really stressed. He's going through a divorce and he's not been sleeping well, or he's eating a terrible diet. He's eating, you know, mostly food that's out or pre-prepared food. He's been stressed and having a lot of muscle pain, and so he's been taking ibuprofen 800 3 times a day for joint pain. He's not a smoker, but he has been drinking more kind of through all this stress. And he does have a family history of coronary artery disease with a dad who had a heart attack in his 60s. So what would you maybe encourage this patient to do? So think about counseling, just for, I don't know, if the patient's open to that. Sleep hygiene, talk to them about how important sleep is, and think about whether this patient needs to be screened for obstructive sleep apnea. Remember, the BMI is 32, so may qualify. Encourage just movement. It doesn't have to be exercise, but just more movement. Encourage some small changes to the diet if you can, and weight loss. All of that, again, might not be in a place at that moment to make these changes, but it's important for him to hear them as he comes in to see you. Definitely stop the ibuprofen. And you know, tell him that if you stop the ibuprofen, you know, maybe we won't need to start medications for the high blood pressure. And then, of course, advising to minimize alcohol. You know, if these things or some of these things are done, then maybe you can avoid having to treat. So you advise on some lifestyle modifications. You send him on his way. He returns 3 months later after trialing these, and unfortunately, which we often see, he comes back and he's still hypertensive. He's 140 over 88. He's not lost any weight. And so what do we do for our next step? So So we are now have moved down here on the algorithm. So we've confirmed the diagnosis, and we're really going to consider treatment now. If we've got one more sidebar here, and this is just consideration of any other comorbid diseases that a patient might have that might give you make you have special considerations for their treatment, which does not apply to our patient currently, but it's good to keep in mind. So here we are back at the sort of the meat of these guidelines. So in thinking about wanting to treat this patient, we have to first think about what our target's going to be. So systolic goal less than 130, which is a reasonable place to start. And then you sort of think about how much could your patient tolerate from there. You know, this is a young guy. He could probably tolerate some blood pressures, towards the lower end of 120. And so then how do we get there? What do we use as our first line therapies? For most of our patients, there's the 3 drug classes that we consider first, which is our thiazide type diuretics, ACE inhibitors, ARBs, and our long-acting calcium channel blockers. So those are kind of our 3 go-tos. For our patients who are just a little bit hypertensive, like our patient here, can just start with one monotherapy. For those who are more hypertensive, greater than 20 over 10 millimeters of mercury elevated, then we would consider maybe starting a combination therapy. There are some special considerations here, which we'll talk about a little bit. For our elderly, older patients, thiazide diuretics are recommended for their cardiovascular impacts or reduced risk for cardiovascular endpoints in for the thiazide elevated or reduced cardiovascular endpoints. Again, that you'll have to take that into think about that a little bit, because if you've got a patient who's not so steady or a little orthostatic, maybe you don't want to use the thiazide. So, not everything is super straightforward. Let's go through these a little bit more. So here's our 3 drug classes we're talking about. So for ACEs and ARBs, this we think about using for our diabetic patients. This may help to reduce the incidence of diabetes. So this is something you might think about in your patients who are hypertensive with a metabolic syndrome. It can have to it has been shown to delay from the onset of diabetes in some patients. For good hypertensive coverage for your patients who have normal renal function, lisinopril should be dosed twice a day. And for those with more advanced chronic kidney disease, they can be dosed daily. Thiazides, we prefer chlorothalidone to hydrochlorothiazide. It's just more effective, it's longer acting. But important things to consider and to advise your patients on when you're prescribing this medication is that it can exacerbate erectile dysfunction, certainly requires lab follow-up. There can be metabolic adverse effects, and need to monitor the potassium and the magnesium and the sodium. These are really good choices for our patients who we anticipate are salt sensitive, those who are obese, those of recent African American descent, and those with chronic kidney disease. And they can be synergistic with our ACEs and ARBs. For our calcium channel blockers, these are good in that they don't cause any electrolyte abnormalities or change metabolic profile. So for your patients who might live far away or you're worried about might not be super reliable for follow-up, these are kind of my go-to first-line drugs. And it's important to understand the difference between your dihydropyridines and your non-dihydropyridines, which we'll talk about in just a second. And it's okay to combine those two subclasses, the dihydropyridines and the non-dihydropyridines. So dihydropyridines are the ones we sort of reach for first, is where your nifedipine, your amlodipine. I don't use amlodipine very often. I usually just those first two. And these are more powerful blood pressure lowering medications than the non-dihydropyridines. This is a practice pattern for us here, is that we use nifedipine BID. It just tends to have better coverage in the same way that lisinopril BID does. And we actually use pretty high doses. We go up routinely to 90 BID. Your patients should be advised to never cut these tablets in half because they can become dangerously fast acting. These work by vasodilation, so they can cause edema. Sometimes you can help to reduce this drug effect by either combining them with an ACE inhibitor or dosing them at night. For the non-dihydropyridines, your verapamil, diltiazem, important to remember that these are AV nodal blockers. So use caution in combining them with other medicines that might affect the heart rate. I don't use these a whole lot. I actually tend to transition folks off of these because it will allow me to use a dihydropyridine beta blocker. It sort of opens up two classes of drugs for me. And importantly, there's a lot of drug interactions with these non-dihydropyridines. So what about the beta blockers? They aren't in our first line. They weren't listed. Our first lines were ACE inhibitors, ARBs, thiazide-like diuretics, and calcium channel blockers. So what about the beta blockers? There's obviously different subclasses. And these are not recommended to be first line, but in my own practice, I think that they're not unreasonable to use as either first or second line therapy, at least the vasodilating beta blockers. So carvedilol is a medicine I use very frequently, especially for my patients who are at high risk for coronary artery disease. As long as their heart rates can tolerate a little bit of lowering. Again, side effects to counsel your patients on: it can make people tired, it can reduce their exercise tolerance, and it can also contribute to erectile dysfunction. It does require folks to take multiple day dosing, like the lisinopril that you might dose BID. So not everybody is, that's not a great fit for everybody, but please don't use metoprolol. Metoprolol is not a good antihypertensive. And atenolol, also not a great medicine. So once we choose a medication for our patient, we're going to just monitor him for the effect of the blood pressure. So we're going to ask him to check his blood pressure at home. We're going to bring him back into the office and make sure that we're following up to know how his blood pressure management is going. Optimizing therapy is really deciding whether you need to increase the dose of the initial agent you started or adding another agent, and whether or not you maximize your first medicine before adding a second one is really sort of a matter of preference as far as your practice patterns are concerned. If you're having trouble controlling the blood pressure, this is when you might start thinking about secondary causes. And here, importantly, involving your pharmacists, your nurses, your dietitian, whatever resources your clinic has, is really important and can be really helpful in contributing to adherence and just success in helping manage your patient's blood pressure. I guess I should have said this from the beginning. If anyone's got questions or wants to make comments or toss anything out into the question and answer, please feel free. Okay, so this is our second case. This is a quick one, quick straightforward case. This is a 75-year-old guy. He comes in to see you for some lower urinary tract symptoms. So he's having some obstructive symptoms. He's not taking any medicines. I don't know, I don't have this patient in my clinic. His blood pressure is 120/75 with a heart rate of 8. And so the question is, do you start him on doxazosin for BPH? Is that what, and would any of you guys start him on that as your first line? What about if his blood pressure was 160/75? Would doxazosin be a good first line agent for him with his urinary tract symptoms? He was hypertensive and not on any other medications. The word, so don't, please don't. So while that is a good idea, because doxazosin that can be a medicine that can treat both the prostate issues and the blood pressure. It was shown in the ALLCAT trial. It was actually the monotherapy doxazosin arm was terminated due to excess of CHF. And this was felt to potentially be due to reflex tachycardia. So again, in my own practice, I tend to use tamsulosin or alfuzosin or when I'm treating BPH and don't need the blood pressure lowering effect. And I treat lots of BPH because it's important for the kidney health. And I do this especially in older and folks with fall risk, and still advising them of the risk of being dizzy or lightheaded. And then if I have a hypertensive patient who also is having obstructive symptoms, and I do use alpha blockers, but if they're not already on a beta blocker, then I make sure they're on I prescribe a low dose beta blocker if their heart rates then can tolerate. So then you'd be starting a low dose of both an alpha blocker and a beta blocker. And that's just to prevent that reflex tachycardia. Okay, the third case. This is a 55-year-old guy, diabetes and hypertension. He comes to clinic for annual follow-up. His blood pressure is a little bit elevated. It's 140/95 in both arms. BMI is 31 instead of normal heart rate. He's on nifedipine and atenolol. He's got a normal creatinine, and his microalbumin creatinine ratio is 10 milligrams per gram. So he has no albuminuria by quantification. So what now? The question for this case is, he has diabetes. Does that mean we have to use an ACE inhibitor in ARB? Are they mandatory? So in thinking about diabetic nephropathy, this happens to about 30% of our diabetics. And it is one of the most common causes of ESRD in the United States. So certainly something we want to monitor for and treat and try to prevent. It usually is proteinuric, though you can have folks who have non-proteinuric diabetic nephropathy, though for the most part, we consider this a proteinuric disease state. And the typical progression through time is that a patient will develop microalbuminuria, which is actually not a term we use anymore, but it is just small amounts of albumin in the urine that can only be detected by the albumin creatinine ratio. So you have a small amount of albumin in the urine with a normal creatinine. They then progress to have frank proteinuria, which is protein or albumin that can be detected by a urine dipstick. So that's greater than 300 milligrams per day, still maintaining a normal creatinine and normal renal function. And then in the final stage, kind of transition to abnormal creatinine with ongoing or progressive proteinuria. But our strongest data for use of ACE inhibitors, ARBs, are those with the heaviest proteinuria. We don't have any data to support ACE inhibitor or ARB use over any other agent for hypertension for our patients with diabetes and no albuminuria, or our patients with CKD and no proteinuria. That doesn't mean you shouldn't use them, but you should think about your patient as a whole and other comorbidities that your patient might have. So if you have a patient who, say, has diabetes, is non-proteinuric, is hypertensive, and has irritable bowel syndrome, diarrhea, predominant irritable bowel syndrome, and tends to get volume depleted. An ACE inhibitor, an ARB, is not the best choice. You would be running the risk of your patient getting an acute kidney injury on an ACE inhibitor if they were to get dehydrated while having diarrhea. So there's nothing wrong with then using a calcium channel blocker to treat hypertension in a patient like that. So you don't have to feel like just because a patient carries a diagnosis of diabetes on their problem list that you have to use ACEs and ARBs, or if they have chronic kidney disease that you have to use ACEs and ARBs if they're not otherwise, they don't otherwise feel like a safe fit, especially if they don't have proteinuria. And just to prove that I'm not making things up, the American Heart Association agrees with this, and this is their recommendation as well. So they say that with albuminuria greater than 300 milligrams per day, which is typically by urine protein creatinine ratio, or greater than 300 milligrams per gram, which would be measured by an albumin creatinine ratio, ACE inhibitors or ARBs would be the first choice, first line therapy. And if they don't, then whatever you want to use is appropriate. So ACEs and ARBs and diabetes, when to consider it. If they're proteinuric, and by that you typically mean albuminuric, which we'll talk about in a little bit. So that's greater than 30 milligrams of albuminuria, milligrams per gram albuminuria by the albumin creatinine ratio, or enough to show up on a dipstick, which is greater than 300. And importantly, they have to be able to tolerate it. So we expect some increase in creatinine, and we'll talk about physiologically why that is. But it shouldn't be more than 30% increase in the creatinine. So proteinuric, you put them on lisinopril, you recheck their creatinine. As long as their creatinine doesn't bump too much, they don't have hyperkalemia, and their blood pressure doesn't drop too much, then that's a good choice. Times to not consider ACE inhibitors or ARBs in diabetes are if they're not hypertensive. So you don't have to have them on it, certainly if they're not hypertensive. That's just going to create a whole nother problem. If they're already on an ACE or an ARB, you can still combine those ever. If they're on chronic non-steroidals, if they're on spironolactone, eplerenone, aliskiren, we'll say don't use them. We'll say don't use them. I sometimes use them with caution and close lab follow-up. If they've got a history of significant acute kidney injury, that may lead you to think about something like bilateral renal artery stenosis and probably shouldn't be retrialed. Bladder outlet obstruction or volume depletion, like we just talked about, those would be times to think that maybe the risks of the medication might outweigh the potential benefits. And then if the patient's unreliable for follow-up, if you really think they're just not going to come back, then the risks of the medicine, it might not be a safe medicine choice if you don't think they're going to come back to be able to ensure that they're not hyperkalemia. But this piece I'm going to dwell on for a quick second. The dangers of, or the reason why ACE inhibitors, ARBs plus non-steroidals is so bad for the kidneys. So this is a very simplistic diagram of a glomerulus. So in proteinuric disease like diabetes, the afferent arteriole is dilated and it transmits high systemic blood pressure into the glomerulus, which over time, these high blood pressures into these little capillaries causes damage and can lead to proteinuria, which is why ACE inhibitors and ARBs are a great choice for our patients with proteinuric hypertension and proteinuria. What the ACEs and ARBs do is they dilate the efferent arteriole, which then minimizes the pressure in the glomerulus, in the little capillary tuft. which decreases the amount of protein that gets pushed through to the urine, decreases the pressure overall, decreases the amount of protein that gets pushed through, and also results in a decrease in GFR, which is why we expect there to be some bump in the creatinine when we start lisinopril or losartan. And again, as long as it's less than 30%, you're okay with that. And I usually advise my patients that, I anticipate your creatinine might go up a little bit. And that really tells me that the medicine's actually doing what it should be doing. We just want to make sure it doesn't go up too much. So NACE and ARB, you're dilating your efferent arteriole. And when you add a non-steroidal to it, this causes afferent arterial constriction. So you've got something here that's decreasing GFR, and then you add another med that further decreases GFR. And this is just a perfect story for causing an acute kidney injury. So please don't use ACEs and ARBs if you've got somebody on non-steroidals, or if you can stop the non-steroidals, that's obviously. All right, last case here. I think this is my last case. This is a 62-year-old gentleman, type 2 diabetes, hypertension, hyperlipidemia. He's on a lot of meds. He's on amlodipine, maximum dose, lisinopril, maximum dose, lipid metformin, simvastatin, and he's on diclofenac, 50 milligrams BID. He's a little hypertensive, 148/88, BMI is 32. He's got a little bit of edema on exam. CBC looks pretty good. Cholesterol doesn't look so good. BMP, the sodium, potassium, bicarb, looks all right, but he does have an elevated creatinine and a GFR of 33 with a UA that shows 1+ protein. So this guy has like all the things, right? He's got diabetes, he's got hypertension, he's got CKD, and he's got proteinuria. So what are we going to do with this guy? This is going to lead us into talking a little bit about chronic kidney disease, using the proteinuria as our transition point here, because you can't really talk about all this without talking about CKD. So just to briefly talk about definitions, CKD is a GFR less than 60 and or kidney damage. Kidney damage being defined as proteinuria, so abnormal urine findings or abnormal imaging finding. And then ESRD is, of course, a GFR less than 10 that's not reversible in a patient that requires renal replacement therapy, so has symptoms of their renal failure that cannot be medically managed. Really common, similar to the hypertension, 14% of the US population. So this is the most recent CDC data. So 35.5 million people have CKD, and most of them don't know they have it. So another important one to look for, because there's no symptoms and people won't know unless you look for it. And diabetes and high blood pressure are the most common causes. So this really falls into the primary care lab for detection. We've all seen the heat map. So the way that we are to classify CKD now is really supposed to be presumed etiology, stage, which is based on the GFR, and then the amount of albuminuria. And that's based on an albumin creatinine ratio. So undetectable albumin, so less than 30 milligrams per gram, between 30 and 300, and then greater than 300. And you can see as the GFR increases and as the protein or the albumin in the urine increases, these patients are at significantly higher risk for progression to ESRD, for morbidity and mortality, and to talk about right now for cardiovascular disease. So cardiovascular disease is what our patients die from. CKD patients are 100 times more likely to die than ever reach ESRD. So Dr. Rueda always jokes that he congratulates his patients when they get to ESRD and they get to dialysis because they haven't, they've kind of made it past this major risk. This is just kind of showing that in graph form. that you can see the hazard ratio for cardiovascular mortality is increased at a GFR just below 60. And this graph is significantly amplified if you add in concomitant albumin. It's a bad combo. We care about renal function, and by that I mean the GFR for drug dosing, for predicting kind of problems that we might have in months, years to come, and really for educating patients and family on, anticipatory guidance on what we expected. So we often use creatinine. Creatinine is a breakdown product of muscle, so it's continually being made, freely filtered into the urine of the glomerulus, with the tiny little bit being secreted in the distal tubule. And because most of the creatinine that's in the urine is freely filtered, we use the clearance of creatinine from the blood to be an estimate of glomerular filtration. There's different formulas that we can use to calculate the GFR. MBRD, CKD epi is the most common one. Don't do 24-hour urine collections. This is just an aside. For any reason, don't do them. They're cumbersome for your patients. We don't need to calculate creatinine clearances that way. Our labs and estimated GFRs are more than reliable enough. And so this is less of an issue now, I think, than it used to be, in that most of our labs all come with a GFR calculated now. But this is just to remind you that a creatinine of 1 or a creatinine of X of whatever doesn't mean the same thing for every patient. So you have to think of your patients, or think of your creatinine in the context of the patient sitting in front of you. So this was just to show that depending on the age and the gender of your patient, a creatinine of 1 can mean very different things for the calculated GFR. That's always a very important thing to remember. And also important to remember that the eGFR is estimated, and it's based on population data. And so it's not a patient's actual GFR, it's really the best guess that we have, the best estimate that we have. Not reliable in our patients who've got GFRs greater than 60. GFRs are definitely not reliable in a dynamic situation. So in an acute kidney injury, we don't use GFRs. We speak more in creatinines. Hard to rely on a calculated number when things are in flux. And then extremes of muscle mass can also make our GFR calculations that are based solely on creatinine and make us wary that they're not entirely accurate. Which brings us to cystatin C, which I make a major plug for. I check this in a lot of my patients. Cystatin C is another marker of kidney function. It's a low molecular weight protein. It's filtered at the glomerulus. It's not resorbed, but it can't be used directly for clearance because it is metabolized in the tubules. And then it's produced by all nucleated cells, not just muscle cells. So it can be a good option for folks who have muscle masses on the extreme ends. It, of course, is not without its own, I'd say, issues. Nothing is a perfect test, but this has proven to be a pretty useful lab test in helping understanding what patients' GFRs may be. So here's just an example of a patient who I saw in clinic who came in with a creatinine of 1.3, but was quite thin. I can't remember if they had liver disease, and had a metabolic electrolytes that looked consistent with more advanced chronic kidney disease. Potassiums were a little high, phosphorus was a little high, the bicarb was a little bit low. And so I was suspicious that my GFR calculation based solely on creatinine was overestimating his renal function. So I checked a cystatin C, which indeed was higher at 2.7. So once you get these two values, and cystatin C can be added onto the same tube, same chem panel tube as a BMP. And here they come back actually faster than our creatinines do. It's a pretty fast turnaround. You can then just type into whatever search browser you use, GFR calculator, and this NKF page usually pops up first. This is the calculator. You can just put in creatinine, the cystatin C, the age, and the gender. And it gives you this. It uses 3 separate formulas to calculate the GFR. The first is CKD epi, which is the formula used at least in EPIC or in our CPRS in our medical record systems here. The lower one is CKD epi cystatin C, which is typically much lower. And then the middle equation is the one I tend to go by, which is a combination of the creatinine and cystatin C, the CKD epi creatinine and cystatin C equation. And this gives you a pretty large spread. And what I usually show this to patients, and I'll say, you know, what this tells me is that we don't know exactly what your kidney function is, but I suspect that it's more advanced than the labs in the medical record show, and that I would guess that this patient's GFR is closer to this 35 range, which is really important for patients who need antibiotics or medicines that need to be read. Does anybody have any questions on that? Or I guess questions. So then after the GFR, it's important to think about proteinuria. So this helps us think about the cause of underlying CKD and helps us think about targeting therapy. So should we start an ACE inhibitor or an ARB? And again, this is the biggest risk factor for progression of CKD and for cardiovascular. So we're going to spend a couple slides on this. It is normal to have some protein in the urine. So total protein in the urine is anywhere between 150 and 200 milligrams per day. Less than 10 to 20 milligrams of that is albumin. And so the rest of it is Hamm-Horsfall proteins from the tubules and whatever other proteins end up. Important to know that dipsticks on your urinalysis detect only albumin, and they only detect albumin when they're at levels greater than 300 milligrams per day. So smaller amounts require the albumin creatinine ratio. And as we've seen, because of the prognostic, the prognostic ability of this test as relates to cardiovascular disease is a really important test to get in your diabetics on a yearly basis and to think about getting in your diabetics. This used to be called microalbuminuria because it was micro, too small to be seen on the dipstick. I guess it's not called that anymore. So this is talking about the difference between albumin creatinine and the protein creatinine. And so oftentimes those terms are used interchangeably. They are not the same thing. So I said that there is some amount of protein is normal in the urine, and it's not all albumin. So there's this Hamm-Horsfall protein that comes from the renal tubular epithelial cells in the distal tubule. So albumin creatinine ratio is what our staging of chronic kidney disease is based on. It's what we use for our diabetics. It is often the recommended test. It's more sensitive, it's specific. It worsens our CKD, it worsens in our CKD. When you have an elevated albumin creatinine ratio, our CKD outcomes and our cardiovascular outcomes are worse. It tends to be more accurate than our urine protein, but it is also more expensive. So I actually tend to follow protein creatinine ratios in a lot of my patients. routinely when I'm seeing them regularly due to this cost, unless their protein creatinine ratio is undetectable. So if it's very small, then I switch over to the albumin creatinine ratio because it does detect smaller levels of protein. And that's just kind of in my own practice. This is here to remind me to remind you guys that the quantification of the proteinuria is really important, and you can't just trust the dip. So the dipstick or the urinalysis protein, you always have, in the same way that you have to think about your creatinine in the setting of your patient, you have to think about your dip protein on your urinalysis in the context of the specific gravity. So specific gravity is telling you about the concentration of the urine. So if you have a really concentrated urine, say a specific gravity of 1025, and trace protein, likely if you were to quantify that, it would be really minimal protein. It was showing up on the dipstick because the urine was so concentrated. So that can be a false positive protein dip. And the opposite can also be true. If you've got a really dilute urine, say 1005, and a negative dip for protein, that should still be quantified because you might have loads of protein and you're missing it because the urine is so dilute. So always quantify. If you've got chronic kidney disease, diabetes, hypertension, quantify your proteinuria. That's my plug. Let's see. So we care about this. It causes glomerular hypertension and hyperfiltration, which leads to damage of the glomerulus. This is one of the earliest markers of kidney disease. And as it increases, it can lead to ongoing damage. So our goal is to minimize the protein in the urine with the idea of slowing the progression of chronic kidney disease. We have multiple ways to do this now: ACEs, ARBs, SGLT2 inhibitors, mineralocorticoid receptor antagonists, which is a talk for another day. But those are the medicines you should think about when you've got a proteinuric patient. So we want to slow the progression of CKD by treating the underlying cause. So hypertension or diabetes. Look for the proteinuria and treat it if you can. If you think your patient can tolerate it, push that blood pressure down into the low 120s. So if you've got your 30-year-old patient who's got 2 grams of protein, you can probably push that patient's blood pressure lower than you can your 80-year-old patient who's orthostatic. So you can remember that you you don't have to be stuck on an algorithm. So look at your patient and all of the comorbidities when you're thinking about how best to treat them. And then do all of the lifestyle things: tobacco cessation, lowering lipids, encouraging exercise and weight loss. All of this is not only going to help treat hypertension when you have it, but it's also going to help slow the progression of chronic kidney disease. These are complications that you might expect from chronic kidney disease. Most of these are addressed by nephrologists, but importantly, hypertension is one of the earliest causes. It might be the first symptom or sign of chronic kidney disease, and that you guys are going to be on the front lines of recognizing this. So this sort of brings us back to where we started, in that hypertension and chronic kidney disease can go hand in hand. And it's important to look for both of them. So this is my last slide. So this is just a summary. Hypertension and CKD they're both really common. They're both really serious. Important to consider lifestyle modifications. Don't underestimate that, but know that you're going to have to repeat it, and that it's hard for patients. One size doesn't fit all in terms of medical therapy. So know that you are going to have to jump off algorithms. You can't stick on an algorithm because individual treatment doesn't always fit on an algorithm. And I guess that's what the last point is that they can be helpful, but know when you need to hop off of them. And so with that, I am gonna turn things over to Dr. Rueda.